Hello everybody. Today we are going to discuss the guidelines for the acute coronary syndrome. So the dose regimen and this is the part two, which is a continuation of the part one. So in this we'll see the dose, the antiplatelets and the anticoagulants which are used in the acute coronary artery syndrome. So the antiplatelet agents are like aspirin, loading dose of 150 to 300 mg orally and 75 to 2 mg or 250 mg IV if oral injection is not possible, followed by the oral maintenance dose of 75 to 100 mg OD. Then the next class of drug is the P2Y12 receptor inhibitor, that is clopidogrel. The loading dose is 300 to 600 mg orally, followed by the maintenance dose of 75 mg OD. No specific dose adjustment in the CKD patient. Fibrinolysis, at the time of fibrinolysis, an initial dose of 300 mg should be used. Then the prasugrel, the loading dose is 60 mg, followed by the maintenance dose of 10 mg. In patient with the body weight of less than 60 kg, maintenance dose of 5 mg OD is recommended. In patient age more than or equal to 75 years, prasugrel should be used with caution with maintenance dose of 5 mg OD if treatment is deemed necessary. Ticagrelor, the loading dose of 180 mg orally, followed by the maintenance dose of 90 mg BD. No specific dose adjustment in the CKD patient is needed. Then Cangrelor, the bolus of 30 mics per kg IV, followed by the 4 mics per kg per minute infusion for at least 2 hours or the duration of procedure. In the transition from canaglilol to thiopyridine, the thiopyridine should be administered immediately after discontinuation of canaglilol with the loading dose to avoid potential drug dose interaction. Prasugrel may also be administered 30 minutes before the canaglilol infusion is stopped. Then ticagrelor, that is loading dose of 180 mg, should be administered at the time of PCI to minimize the potential gap in the platelet inhibition during this transition time. Glycoprotein, the next class of drug is glycoprotein 2B3A inhibitor. In this, the drug is eptifibatide, that is the double dose of 180 mics per kg, followed by the infusion of 2 mics per kg per minute for up to 18 hours. For creatinine clearance of 30 to 50 ml per minute, first loading dose, that is 180 mics per kg IV bolus, maintenance infusion, and then 1 mics per kg per minute. Second loading dose of 180 mics per kg IV bolus should be administered 10 minutes after the first bolus. Contraindicated in patient with end-stage renal disease and with prior ICH, ischemic stroke within 30 days, fibrinolysis and platelet count less than 1 lakh. Tirofiban, bolus dose of 25 mics per kg over 3 minutes, followed by the infusion of 0.15 mics per kg per minute for up to 18 hours. Then unfractionated weight heparin, the initial treatment, IV bolus of 70 to 100 unit per kg, followed by the infusion titrated to achieve activated partial thromboplastin time of 60 to 80. During PCI, it should be administered in the dose of 70 to 100 unit per kg IV bolus. Then enoxaparin, initial treatment of ACS 1 mg per kg BD subcut for minimum of 2 days and continued until the clinical stabilization. In patient with the creatinine clearance below 30 ml, enoxaparin dosage should be reduced to 1 mg per kg OD. During PCI, for management with PCI, the last dose of enoxaparin should be given less than 8 hours before balloon infusion. No additional dosing is needed if the last subcut administration was given more than 8 hours before a balloon infusion, and IV bolus of 0.3 mg per kg of enoxaparin sodium should be administered. Then bivalirudin during PCI 0.75 mg per kg IV bolus followed by the infusion of 1.75 mg per kg for 4 hours after infusion. In patient with those creatinine clearance is less than 30 ml per minute, maintenance infusion should be reduced to 1 mg per kg per hour. Then fondaparinux, initial treatment is 2.5 mg per day subcute. During PCI, the single bolus of unfractionated heparin is recommended. Avoid if creatinine clearance is less than 20 ml per minute. So this is the schematic representation of various antiplatelet, anticoagulant, anticoagulant drug that are used into the management of the ACS. That is, the aspirin will act on the thromboxane receptor. Then the P2Y12 receptor inhibitors are clopidogrel, ticagrelor, prasugrel, and the canagrelor. Then glycoprotein 2B3A receptor inhibitors are ectifibatide and tirofibatide. Then this factor 10A inhibitors are rivaroxaban, apixaban, endoxaban, and the fondaparinux. Enoxa, then uh, uh, these the dabigatran bivalirudin will act on thrombin and the unfractionated weight heparin and enoxaparin will act on the factor 10. So antiplatelet therapy in the acute phase, oral antiplatelet therapy. Antiplatelet drug plays a key role in the acute phase of treatment for ECs. The choice of antiplatelet regimen should take the bleeding risk of patient into account. Factors associated with elevated bleeding risk have been detailed by the Academic Research Consortium on High Bleeding Risk. The presence of one major or two major ARC high bleeding risk factor indicate the high bleeding risk. Of note, the presence of multiple major risk factor is associated with the progressive increase in the bleeding risk. Aspirin treatment is started with the loading dose as soon as the possible, followed by maintenance dose. Current evidence supports the aspirin maintenance dose of 75 to 100 mg per once in a day. Based on the result of active phase 3 platelet inhibition and the platelet patient outcome, that is plateau trial, to assess the improvement in the therapeutic outcome by optimizing platelet inhibition with the prasugrel. Thrombolysis in myocardial infarction studies, dual antiplatelet, including aspirin and potent P2Y12 receptor inhibitor, is recommended as the default DAPT strategy for ACS patients. Clopidogrel, which is characterized by the less effective and more variable platelet inhibition, should only be used when prasugrel and ticagrelor are contraindicated and not available, and in some patients considered otherwise at high bleeding risk. For example, more than one major or more than or equal to two minor ARC HBR criteria. In addition, the use of clopidogrel may be considered in older patients, that is more than or equal to 70. Prasugrel should be considered in preference to ticagrelor for ACS patient who proceed to PCA. Intracoronary stenting and intrathrombotic regimen, rapid early action for coronary treatment, that is ISAR react RCT, is the largest head-to-head comparison of 1 year DAPT with prasugrel versus DAPT with ticagrelor in patient with ACS planned for invasive evaluation, more than 80% of whom underwent PCA. A treatment strategy with prasugrel, that is loading dose given as soon as possible after randomization for patient undergoing PCA and after delineation of coronary anatomy for patient presenting with NSTEMI versus ticagrelor, significantly reduce the composite endpoint of death, MI or stroke without increasing bleeding complication. The limitation of the study, including open label design and limited data on medically managed or CABG treated patients. Timing of the loading dose of oral antiplatelet therapy. Both aspirin and oral P2Y12 inhibitor achieve platelet inhibition more rapidly following an oral loading dose. Pretreatment refers to the strategy in which antiplatelet drug, usually P2Y12 receptor inhibitor, is given before coronary angiography and therefore before coronary anatomy is known. Although potential benefit with pretreatment in setting of ACS has been hypothesized, and large-scale randomized trials supporting a routine pretreatment strategy with P2Y12 receptor inhibitor are lacking. Caution in relation to the pretreatment may be of particular relevance in patient at high bleeding risk. Pretreatment in patient with suspected STEMI. The administration of the ticagrelor in cath lab or in ambulance for new ST segment elevation myocardial infarction to open coronary artery, that is Atlantic trial, is the only randomized study testing the safety and efficacy of different timings of P2Y12 receptor inhibitor initiation in patient with working diagnosis of STEMI undergoing PCI. In this trial, patients were randomized to receive ticagrelor loading dose either during transfer to PCI center or immediately before angiography. The median difference between the timing of P2Y12 receptor inhibitor loading with two treatment strategy was 31 minutes. In this study, the pretreatment strategy failed to meet pre-specified primary endpoint of improved ST segment elevation resolution or thrombolysis in myocardial infarction flow before intervention. The rates of major and minor bleeding events were identical in both treatment arms. These results were supported by real-world data obtained from Sweetheart registry in STEMI patients. Prasugrel pretreatment has not been directly investigated in patients with STEMI. Pretreatment in patients with NSTEMI acute coronary syndrome. A randomized comparison of the prasugrel at the time of percutaneous coronary intervention or as a pretreatment at the time of diagnosis in patient with NSTEMI trial, that is ACOS trial, not only demonstrated lack of benefit with respect to ischemic outcome with prasugrel pretreatment, but also substantially higher bleeding risk. In this study, the median time from the first loading dose to the start of coronary angiography in the pre-treatment group was 4.4 hours. With respect to the pre-treatment data for ticagrelor, ISAR REACT trial showed that ticagrelor-based strategy with routine treatment was inferior to the prasugrel-based strategy with deferred loading dose in NSTEMI patients. The dubious that is downstream versus upstream strategy for administration of P2Y12 blocker trial also attempted to address this question but was stopped early for futility as there was no difference between upstream or downstream oral P2Y12 administration in patient with NSTEMI ACS scheduled for coronary angiography within 72 hours of hospital administration. Now the summary of the pre-treatment strategy. In patient with working diagnosis of STEMI undergoing PCI, pre-treatment with P2Y12 receptor inhibitor may be considered. In patient with working diagnosis of NSTEMI, routine pre-treatment with P2Y12 receptor inhibitor before knowing coronary anatomy in patient anticipated to undergo early invasive strategy and pre-treatment with the P2 and pre-treatment with the P2Y12 receptor inhibitor may be considered according to the bleeding risk of the patient. In all ACS patients proceeding to the PCI who did not receive P2Y12 receptor inhibitor pre-treatment, the loading dose is recommended at the time of PCI. Now the intravenous antiplatelet drug. The peri-interventional IV antiplatelet drug include P2Y12 receptor inhibitor, that is cantrelor, or glycoprotein 2B3A inhibitor, that is eptifibatide and tirofiban. Most of the trial evaluating glycoprotein 2B3A inhibitor in PCI-treated ACS patients predate the era of routine DAPT, in particularly early initiation of DAPT, including loading dose of potent P2Y12 receptor inhibitor. There is no strong evidence for any additional benefit with the routine use of glycoprotein 2B3A inhibitor in ACS patients scheduled for coronary angiography. Nevertheless, their use should be considered for bailout if there is evidence of no reflow and thrombotic complication during PCI. Another potential use for glycoprotein 2B3A inhibitor is in the setting of high-risk PCI patients who have not been pre-treated with P2Y12 receptor inhibitor. Cangrelor is the direct reversible short-acting P2Y12 receptor inhibitor that has been evaluated during PCI for CCS and ACS in clinical trial against the clopidogrel. Both the administration before that is cangrelor versus standard therapy to achieve optimal management of platelet inhibition, that is champion PCA, and after this champion platform and champion Phoenix, a clinical trial comparing cannular and to clopidogrel standard therapy in patients who require PCA. A meta-analysis of this trial showed that benefit of the cannular with respect to major ischemic endpoint was counterbalanced by increasing minor bleeding complication. It is also important to note that benefit of cangrelor with respect to ischemic endpoint was attenuated in champion PCI with upfront administration of clopidogrel, and data for its use in conjugation with ticagrelor and prasugrel treatment are limited. Due to its proven efficacy in preventing intra-procedural and post-procedural shunt thrombosis in P2Y12 receptor inhibitor new patient, cangrelor may be considered on case-by-case basis in P2Y12 receptor inhibitor new ACS patient undergoing PCI, including patient for whom it may not be feasible to give oral drug in setting of emergent PCI. Now, anticoagulation treatment in acute phase. Anticoagulation is important component of initial treatment of ACS and peri-procedural treatment for ACS patient managed with invasive strategy. Therefore, parenteral anticoagulation is recommended for all ACS patients at the time of diagnosis. In general, crossover between the anticoagulant should be avoided in patients with ACS, especially between unfractionated weight heparin and low molecular weight heparin, with exception of adding unfractionated weight heparin to fondaparinux. When patient presenting with the NSTEMI, proceed to PCI after period of fondaparinux treatment. Anticoagulant should generally be discontinued immediately after PCI, except in specific clinical settings such as confirmed presence of LV aneurysm with thrombus formation or AF requiring anticoagulation. In addition, for bivalirudin in patient with STEMI undergoing PCI, a full dose post-PCI infusion is recommended. In this section of this, in this guideline, the guideline summarize the recommendation for anticoagulant treatment in acute phase for patient with STEMI undergoing PCI and for patient with NSTEMI undergoing angiography. Anticoagulation in patient with STEMI myocardial infarction undergoing PCI. Unfractionated heparin have been established as a standard of care in patients with STEMI undergoing PCI due to its unfavorable risk and benefit profile. In this patient, anticoagulation should be given during the invasive procedure. High quality evidence with respect to benefit of administering anticoagulation at an early time point in patient undergoing PCI strategy is lacking. Alternative to unfractionated weight heparin should be considered in patients with STEMI undergoing PCI, including enoxaparin and bivalirudin. A tall trial reported a reduction in primary endpoint at 30 days with enoxaparin in comparison to unfractionated weight heparin in patients with STEMI undergoing PCI. In the bivalirudin and prolonged full dose infusion during primary PCI versus heparin trial, that is BRIGHT trial. Total 6,016 patients with STEMI undergoing PCI were randomized to either bivalirudin and unfractionated weight heparin. So the use of glycoprotein 2B3A inhibitor was restricted to the patient who experienced thrombotic complication. The primary endpoint, that is all-cause mortality, bleeding, uh, the individual component of the primary endpoint, and definitive and the probable stent thrombosis were all significantly reduced in bivalirudin group. So bivalirudin is also recommended alternative to unfractionated weight heparin in patients presenting with NSTEMI who have history of heparin-induced thrombocytopenia. So based on the result of OASIS trial, fondaparinux is not recommended in patients with STEMI undergoing PCI. To summarize, parenteral anticoagulation is recommended for patients with STEMI undergoing PCI and unfractionated weight heparin is default choice of anticoagulant at present. Enoxaparin and bivalirudin should be considered as an alternative to unfractionated weight heparin, but fondaparinux is not recommended. Now, the anticoagulation in patient with NSTEMI undergoing angiography and PCI if indicated. Patients with the NSTEMI ACS are also recommended to receive parenteral anticoagulation. In patients with NSTEMI ACS who are anticipated to undergo immediate or early invasive angiography and PCI, if indicated, then parenteral anticoagulation at the time of diagnosis is recommended, and unfractionated weight heparin has been historically established as an anticoagulant of choice. However, in meta-analysis of trial comparing unfractionated weight heparin with enoxaparin, mortality and major bleeding was not different between the both agents in patients with NSTEMI ACS and stable patients scheduled for PCI. Therefore, enoxaparin should be considered as an alternative to unfractionated weight heparin in this patient. NSTEMI ACS patients who do not undergo early invasive angiography, that is within 24-hour diagnosis, will have extended initial treatment phase consisting of only pharmacological treatment. In this patient, fondaparinux therapy is recommended in preference to enoxaparin while awaiting invasive angiography based on the favorable outcome demonstrated in the fondaparinux in comparison to enoxaparin in fifth organization to assess strategy in acute ischemic syndrome trial, that is OSIS file trial. Of note, guiding catheter thrombus formation was of concern with fondaparinux. Therefore, full dose of unfractionated weight heparin should be given if patient proceed to PCA. The potential impact of contemporary changes in clinical practice on treatment effect observed in OSIS 5 should be considered. If fondaparinux is not available, enoxaparin should be considered for this patient. Intravenous enoxaparin should also be considered as an anticoagulant for PCI patient with NSTEMI in whom subcutaneous enoxaparin was used while awaiting coronary angiography. In summary, parenteral anticoagulation is recommended for patient with NSTEMI ACS. For patient with NSTEMI ACS undergoing immediate or early angiography, unfractionated weight heparin is recommended, but enoxaparin should be considered as an alternative to unfractionated weight heparin. For patients with NSTEMI ACS who are anticipated to undergo early angiography, fondaparinux is recommended in preference to enoxaparin, although enoxaparin should be considered if fondaparinux is not available. Maintenance antithrombotic therapy after revascularization. Following PCR, default DAPT regimen consisting of potent P2Y12 receptor inhibitor, that is prasugrel, ticagrelor, and aspirin, is generally recommended for 12 months, irrespective of stent type, unless there are contraindications. A specific clinical scenario, default DAPT duration can be shortened and modified. So this is the recommendation for STEMI as well as NSTEMI. So STEMI patient who underwent the PCI, we can give the this unfractionated weight heparin is the class 1 indication, enoxaparin class 2, and bivalirudin is the class 3 recommendation. Then we can use the fondaparinux and it has a class 3 recommendation. The patient undergoes NSTEMI within the less than 24 hours, then unfractionated weight heparin as well as enoxaparin we can use, but unfractionated weight heparin has a class 1 recommendation, and also this enoxaparin has class 2 recommendation. If the angiography is performed for more than 24 hours, then fondaparinux. Then routine antiplatelet treatment is aspirin. We can use aspirin, P2Y12 inhibitor. And this aspirin has class 1 recommendation. P2Y12 inhibitor has class 2B recommendation before PCI. And in case of NSTEMI, it has a class 3 recommendation. If patient undergoes invasive coronary angiography, then choice of P2Y12 inhibitor is prasugrel and ticagrelor. If prasugrel and ticagrelor is not available and contraindicated or cannot be tolerated, then clopidogrel has class 1 recommendation. If the patient is proceeding to PCI, then the prasugrel is more preferable than the ticagrelor. Default dual antiplatelet strategy for 12 months of ACS is aspirin plus P2Y12 inhibitor. And default strategy beyond the first 12 months is only aspirin. And both of these has class 1 recommendation. So aspirin is recommended for all patients without contraindication at initial oral loading dose of 150 to 300 mg and maintenance dose of 75 to 100 mg OD for long-term treatment. This has class 1 recommendation and level of evidence A. In all ACS patients, P2Y12 receptor inhibitor is recommended in addition to aspirin given as an initial oral loading dose followed by maintenance dose for 12 months unless there is high bleeding risk. This has a class of recommendation 1 level of evidence A. PPI in combination with the DAPT is recommended in patients with high risk of gastrointestinal bleeding. Class of recommendation 1 level of evidence A. Prasugrel is recommended in P2Y12 receptor new patient proceeding to PCA. That is 60 mg loading dose and 10 mg OD maintenance dose, 5 mg OD maintenance dose for age of the patient more than or equal to 75 years with body weight of less than 60 kg. This is class of recommendation 1 level of evidence B. Ticagrelor is recommended irrespective of the treatment strategy, that is invasive or conservative. Ticagrelor can be given in the dose of 180 mg loading and 90 mg maintenance dose. Clopidogrel can be given in the dose of 300 to 600 mg loading, 75 mg maintenance dose. Is recommended when prasugrel and ticagrelor is not available and cannot be tolerated. It has a class of recommendation 1 level of evidence C. If patient presenting with ACS stop DAPT to undergo CABG, it is recommended to resume DAPT after surgery at least for 12 months. It also has a class of recommendation 1 level of evidence C. Prasugrel should be considered in preference to ticagrelor for ACS patient who proceed to PCA. Class of recommendation 2A level of evidence B. Then glycoprotein 2B3A receptor antagonist should be considered if there is evidence of no reflow and thrombotic complication during PC. Class of recommendation 2B level of class of recommendation 2A level of evidence C. If P2Y12 receptor new patient undergoing PCI, canaglilol must be considered. Class of recommendation 2B level of evidence A. In older ACS patient, especially if high bleeding risk is present, clopidogrel as P2Y12 receptor inhibitor may be considered. Class of recommendation 2B level of evidence B. Retreatment with the P2Y12 receptor inhibitor may be considered in patient undergoing primary PCI strategy. Treatment with the P2Y12 receptor inhibitor may be considered in end-STEMI patients who are not expected to undergo early invasive strategy and do not have high bleeding risk. Pre-treatment with the glycoprotein 2B3A receptor antagonist is not recommended. Routine pretreatment with the P2Y12 receptor inhibitor in end-STEMI patient in whom coronary anatomy is not known and early invasive management is planned is not recommended. Regarding anticoagulation therapy, parenteral anticoagulation is recommended for all patients with ACS. Routine use of unfractionated weight heparin bolus, that is weight adjusted IV bolus, during PCI of 70 to 100 unit per kg is recommended in patient undergoing PCI. Intravenous enoxaparin at the time of PCI should be considered in patient treated with subcutaneous enoxaparin. Discontinuation of parenteral anticoagulation should be considered immediately after invasive procedure. Patient with the STEMI, enoxaparin should be considered as an alternative to unfractionated weight heparin in patient with the STEMI undergoing PCI. Vivalirudin with the full dose post-PCI infusion should be considered as an alternative to unfractionated weight heparin in patient with STEMI undergoing PCI. Fondaparinux is not recommended in patient with STEMI undergoing PCI. Patient with the end-STEMI ACS. For patient with end-STEMI ACS in whom early invasive angiography is not anticipated, fondaparinux is recommended. For patient with end-STEMI ACS in whom early invasive angiography is anticipated, enoxaparin should be considered as an alternative to unfractionated weight heparin. Regarding combination of antiplatelet and oral anticoagulant, As a default strategy for patient with atrial fibrillation and CHADVA score of more than 1 in male and more than 2 in female, after up to 1 week of triple antithrombotic therapy following ACS event, dual antithrombotic therapy using NOVAC at the recommended dose for stroke prevention and single oral antiplatelet agent for up to 12 months is recommended. During PCI, unfractionated weight bolus is recommended in any of the following circumstances. If the patient is on NOVAC and if the INR is less than 2.5 in vitamin K treated patient. In patient with the indication of oral anticoagulant with vitamin K antagonist in combination with aspirin and clopidogrel, careful regulation of the dose intensity of vitamin K antagonist with target INR of 2.2 to 2.5 and time in therapeutic range of less than 70% should be considered. When rivaroxaban is used, the concern about high bleeding risk prevail over ischemic stroke. Rivaroxaban 15 mg OD should be considered in preference to rivaroxaban 20 mg OD. In patients at high bleeding risk, dabigatran 110 mg BD should be considered in preference to dabigatran 150 mg BD for duration of concomitant single antiplatelet and dual antiplatelet. In patients requiring anticoagulation and treated medically, single antiplatelet agent in addition to oral anticoagulant should be considered for up to 1 year. In patients treated with oral anticoagulant, aspirin plus clopidogrel for longer than 1 week and up to 1 month should be considered in those with high ischemic risk and the other anatomical and the procedural characteristics. In patients requiring oral anticoagulant, withdrawing antiplatelet therapy at 6 months and continuing oral anticoagulant must be considered. The use of ticagrelor and prasugrel as a part of triple antithrombotic therapy is recommended. So the recommendation for alternative antithrombotic therapy in patients who are event free after 3 to 6 months of dual antiplatelet and who are not high ischemic risk, single antiplatelet therapy, preferably the P2Y12 receptor inhibitor, should be considered. De-escalation of the P2Y12 receptor inhibitor treatment may be considered as an alternative to dual antiplatelet strategy to reduce bleeding risk. In high bleeding risk patient, aspirin and P2Y12 receptor inhibitor monotherapy after 1 month of dual antiplatelet may be considered. De-escalation of antiplatelet therapy in first 30 days after ACS event is not recommended. Then prolonging antithrombotic therapy. Discontinuation of antiplatelet treatment in patient treated with oral anticoagulant is recommended after 12. Adding second antithrombotic agent to aspirin for extended long-term secondary prevention should be considered in patients with high ischemic risk without high bleeding risk. Adding second antithrombotic agent to aspirin for extended long-term secondary prevention may be considered in patients with moderate ischemic risk and without high bleeding risk. P2Y12 inhibitor monotherapy may be considered as an alternative to aspirin monotherapy for long-term treatment. Now, the suggested strategy to reduce the bleeding risk related to the percutaneous coronary intervention. Anticoagulant doses adjusted to the body weight and renal function, especially in women and older patients. Radial artery approach is default vascular access. Proton pump inhibitor in patient on the dual antiplatelet therapy at higher than average risk of GI bleed. Two or more history of GI ulcer and hemorrhage, anticoagulant therapy, chronic NSAID and the corticosteroid use or use of two or more of like age more than or equal to 65 years, dyspepsia, gastroesophageal reflux disease, H. pylori infection, and chronic alcohol use. In patient with oral anticoagulant, PCI is performed without interruption of the vitamin K antagonist and NOVAC. In patients with vitamin K antagonists, do not administer unfractionated weight heparin if INR is more than 2.5. If the in patient on NOVAC, regardless of timing of last administration of NOVAC, add low dose parenteral anticoagulation, that is the parenteral 0.5 mg per kg or unfractionated weight heparin 60 unit per kg. Aspirin is indicated but avoid pre-treatment with the P2Y12 receptor inhibitor. Glycoprotein 2B3A receptor inhibitor only for bailout and periprocedural complication. Antithrombotic therapy as an adjunct to fibrinolysis. This ISIS-2 demonstrated that benefit of aspirin and fibrinolytics were additive. The first dose of aspirin in the that is 162 to 325 mg should be chewed or given IV and low dose given daily from the next day thereafter. Clopidogrel added to aspirin reduces the risk of CV event and overall mortality in patients treated with fibrinolysis and should be added to aspirin following lytic therapy. Based on available RCT, there is insufficient evidence to support or refute improved outcome with ticagrelor and prasugrel in patients with the STEMI treated with thrombolytics. There is no evidence that administration of glycoprotein 2B3A receptor inhibitor improves myocardial perfusion or outcomes in patients treated with fibrinolysis, or it may increase the risk of bleeding events. Parenteral anticoagulation is recommended until revascularization if performed. Despite the increased risk of major bleeding, the net clinical benefit favored enoxaparin over unfractionated weight heparin in the assessment of safety and efficacy in new thrombotic 3 trial, that is ASCENT trial. In the large enoxaparin and thrombolysis reperfusion for acute myocardial infarction treatment, that is thrombolysis in myocardial infarction trial, a lower dose of enoxaparin was given to patients more than or equal to 75-year-old or to those with impaired renal function. Enoxaparin was associated with the reduction in the risk of death and reinfarction at 30 days when compared with weight-adjusted unfractionated weight dose, but at the cost of significant increase in non-cerebral bleeding complication. A net clinical benefit favors enoxaparin. In the large Oasis 6 trial, fondaparinux was superior to placebo or unfractionated weight heparin in preventing death or reinfarction, especially in patients who receive streptokinase. In the large trial with streptokinase, significant fewer reinfarction were seen with bivalirudin given for 48 hours compared with unfractionated weight heparin, although at the cost of modest non-significant increase in non-cerebral bleeding complication. Bivalirudin has not been studied with fibrin-specific agent, and there is no evidence to support direct thrombin inhibitor as an adjunct to fibrinolysis. Weight-adjusted tenecteplase, low-dose aspirin and clopidogrel given orally and enoxaparin IV followed by subcutaneous administration until the time of PCI represents the most extensive studied antithrombotic regimen as a part of pharmacoinvasive strategy. Now, recommendation for fibrinolytic therapy. When fibrinolysis is reperfusion strategy, it is recommended to initiate treatment as soon as possible after diagnosis, that is within 10 minutes to lytic bolus. Fibrin-specific agent, that is tenecteplase, altiplase, retiplase, is recommended. Half dose of tenecteplase should be considered in patient more than 75 years of age. Then antiplatelet co-therapy. Aspirin and clopidogrel as recommended. Anticoagulation co-therapy with fibrinolysis. Anticoagulation is recommended in patients treated with fibrinolysis until revascularization. Enoxaparin IV followed by subcutaneous is recommended as a preferred anticoagulant. When enoxaparin is not available, unfractionated weight heparin is recommended as weight-adjusted IV bolus. In patient treated with streptokinase, IV bolus of fondaparinux followed by subcutaneous dose of 24-hour later should be considered. Antithrombotic therapy in patient not undergoing reperfusion. Patient with the final diagnosis of ACS who do not undergo reperfusion should receive P2Y12 receptor inhibitor in addition to aspirin and maintain over 12 months unless there is high bleeding risk. Among ACS patients who are medically managed without revascularization, a combination of aspirin and ticagrelor for up to 12 months has demonstrated benefit in comparison to aspirin and clopidogrel. The combination of aspirin and clopidogrel can also be justified in preference to aspirin and clopidogrel if coronary angiography have been performed and CAD is confirmed. As such, potent P2Y12 inhibitor-based DAPT is a reasonable option for patients with final diagnosis of ECS not undergoing reperfusion unless concern over bleeding risk prevail. DAPT regimen based on clopidogrel and aspirin may provide good clinical benefit among older ACS patients. Thank you, guys.